No, we have one more, chapter 6. But chapter 6 is an accessory to the GI tract, so it's the same, it's still GI. Take this off. Other stuff? Yeah, that's why. But we have to do it all in like little sections. Otherwise, I mean, really, intussusception and diverticulitis and volvulus were the only things that I really didn't cover. You folks ready? Yes. All right.
Just kidding. Oh, what did I do? Oh my God, hold on.
If a patient has an ulcer, a peptic ulcer, let's say, where are peptic ulcers found? In the stomach, right? All right. So if a patient has a peptic ulcer, what interventions can we implement to relieve this tension?
Antacids.
Okay, antacids. That will neutralize acidity. What else? What? Okay, Zantac will also neutralize acidity. What interventions can we start implementing to decrease the distension of the abdomen?
Smaller meals?
Suction. Smaller meals as well, but suction is very important. How can we perform suction?
NG2.
NG2. So what's the purpose of an NG2?
Decompress.
Decompress. Okay. Actually, the NG2, guys, has a lot of purposes. The G2 has a lot of purposes. Give medication, give food, decompress. Okay. But essentially, when we have a distended abdomen, we have hypersecretions of acid or blood or whatever the case is. The purpose of the NG tube is to prevent distension. Make sense? All right. If you have an ileostomy, what are you going to need to collect the fecal matter?
Syringe? I mean, wait. Oh, I was thinking of cupping.
What was that? I think someone said it.
To collect
The fecal matter. What do you need to collect the fecal matter? The bag, the ileostomy bag, guys. The bag. What do you need? What's going to be one of your highest concerns for a patient that has a colostomy, ileostomy bag? Skin breakdown. How far from the stoma line do we make the cut? 1/16 to 1/8 of an inch. Okay.
what?
Hold on. I'll repeat it again.
Smarty over there.
Nah. So anyway, if a patient has an ileostomy bag, the patient's going to need an ileostomy bag. An ileostomy. They're going to need a bag to collect the fecal matter. They're going to need skin barrier to protect the skin because erosion occurs of the skin because of the high acidic content in the ileum. Same thing with the colostomy. The stool's not going to be good for the skin, but of course it's worse for the ileostomy. The cutting of the pouch has to be 1/16 to 1/8 of an inch from the border of the stoma. Okay, from the hole, from the artificial hole of the where the ileostomy is at. We're always going to need a bag as long as we have the ileostomy. We're going to also, if we have gas building up, how do we get rid of it?
Just let it go.
Flat. If you have a buildup of flatus, you'll let it go. You will empty it just as you would a bowel movement.
Eructation.
Eructation is burping, but yeah.
That's okay.
That's right. One more thing, guys. This is like for real world stuff. Okay. I've been at work when I'm emptying out an ileostomy bag, and the ileum has a lot of fluid, right? Sometimes if they cough or something happens, it squirts out. So imagine you're like this, and it squirts out. It'd be pretty devastating. It would ruin my life. So make sure you guys are, for these type of patients, guys, when you guys are at work, wear a face shield, it's okay. But what I normally do is I get a damp little washcloth and I just set it over the stone in case the patient does, and they will defecate, by the way, because it happens automatically. So you can just catch it there like a little catcher, okay? All right. What happens if a patient is constipated, right? And can they pass any type of stool?
No.
Okay, usually this is pretty interesting. What ends up happening with people, yeah, they actually can, but it's like if they have for somebody that has IBS, you have a mixture of constipation and diarrhea, right? Let's say I'm constipated. Oh, I can't go. But then I have a little seepage of diarrhea. What does that mean? That you're impacted. That's right. Meaning because I was constipated. I am constipated. But then there's a little seepage of loose stool. That means I'm impacted. So how do we get rid of that? Digital extraction. Okay. A couple of concepts you guys want to be aware of. Okay. When you stimulate the rectum digitally, it stimulates the vagus nerve. Make sure you guys don't do it for more than a minute at a time because the vagus nerve brings down the heart rate. So if you do it for too long, you're in there digging for too long, it's going to stimulate the vagal nerve and the patient might pass out. Okay?
So 1 minute?
Yeah, you want to keep it to less than 1 minute at a time. You want to go in. Digital extraction, your finger. Yeah, your finger. And I've done this before. It sucks because it's really painful for the patient. And like my daughter, I cleaned her last night. She had a bowel movement. And when I cleaned her up, her stool was hard as a rock. So she's a little constipated. These patients, it's the same thing. But my daughter's stool was that big, little pebbles. Your patient, like if I was impacted, what would my stool like? Big old boulders, right? So it's really painful for the patient, guys. Their anus dilates. And you could literally see inside the anus. And you see all the fecal matter. So this is really painful for the patient. You want to I know you're eating, I'm sorry. But yeah. Anyway, so you want to put some type of lubrication in your finger. You don't want to cut them. And remember I explained fissures, little like cuts. Okay, you want to prevent those as well. And usually burns the patient.
Can you put like normal saline to try to like lubricate it a little bit?
You can't put normal saline. Yeah, you can't put normal saline. You want to be careful on what you put in your fingers, guys. Normally, I suggest you guys just put petroleum jelly, lubricant, okay? Or if you guys have KY at the hospital, whatever, sometimes they do have KY jelly. So whatever it is, you want to put some type of lubrication. You don't want to put A&D because you don't want to introduce A&D inside the rectum, okay? It might irritate the patient. Okay, which medication that's an anti-diarrheal is deprived from opium?
Oh no,
Imodium, guys. Remember I talked about that last week? Imodium. Imodium AD, yeah.
Imodium is what?
Imodium is actually derived from opium, from a narcotic medication. What happens, guys? What happens if I'm on a prolonged Demerol or morphine medication? What type of GI? Yeah, constipation. So patients that have long-term or chronic use of opioid drugs, pain medications, they can have opium-induced, okay, or narcotic-induced constipation. Why do the patients get constipated? How does it happen?
Suppressing everything?
Yeah, it's suppressing everything, so it suppresses motility as well. It suppresses motility of the intestinal tract, so that's why patients end up developing that constipation.
So it's kind of like an anti-venom, Imodium. If you have opioids and then you're constipated, the Imodium is like the anti-venom because it leaves opioids. Okay.
No.
You get it.
Oh, I'm sorry.
Question?
Yeah.
If you have a diarrhea,
If you have a what?
if you have the patient has diarrhea,
Yeah.
and you give him an Imodium, is that?
Yeah, it's an anti-diarrheal medication.
But you need to pass out this.
What do you mean you need to pass out the stool?
I mean, the patient needs to release the.
Yeah, eventually, yeah, but what's going to happen with the Imodium, it's going to start slowing everything down first of all, so that will give the intestines more time to bulk up the stool. Yeah, that's what ends up happening. You guys know the difference between your functional and mechanical obstructions? No?
You can still pass PMs and then...
No. Both obstructions, meaning when you have an intestinal obstruction, means the fecal matter can't get through. You have two basic types. You have functional, and you have mechanical.
Mechanical is caused by an occlusion.
Yeah, this is caused by like, you guys seen the movie Jackass? Okay, I'm sure you guys have. Let's say he swallowed a Hot Wheel car. And if the little Hot Wheel car got embedded inside his intestinal tract, this is called a mechanical obstruction. Okay, the guy that inserted the ketchup bottle up his rectum that I told you guys about. Okay, that's a mechanical obstruction because it's something physical. Okay?
What are you talking about that?
Okay, this is it's a mechanical obstruction. Anything that you have a physical mass inside that works as an obstruction, that's mechanical. Now, functional is a little different.
No peristalsis.
They both have no peristalsis. This one eventually, because of the blockage. The reason why this one doesn't have any peristalsis is because usually during like some type of abdominal surgery, which if you guys actually look this up, 90% of the cases due to, post-op, abdominal surgery happened, where the surgeon's in there messing with stuff, moving everything around, he nicks a nerve or he compresses a nerve, so the peristalsis, it stops. In essence, you have another obstruction because the intestine's not working. You could have something called paralytic ileus, meaning when the ileum becomes paralyzed because of some type of functional issue. Does that make sense?
Yes.
Please know the difference between your functional and mechanical obstructions. What's the most common medication that we give, guys? Miss Mignette. Please, put them away. Guys, don't make a jerk out of me. Come on, you're showing her Target stuff. Show it to me later on. Okay, come on, please. What was this? Oh yeah, when it comes to Crohn's disease, guys, or any type of inflammatory bowel disease, what's the first line of defense when it comes to medications that we give?
The one starts with an antibiotics.
What's it called? No, not called anticholinergic.
Susan knows what I'm talking about.
Sulfasalazine. Sulfasalazine. Okay.
It's an anti-inflammatory.
It's an anti-inflammatory medication, guys. Yeah, it's one of the most common ones that we use. Okay, sulfasalazine. If you guys just see me here just looking at this, is because this is stuff that you guys know already. Just going through. Oh, okay. If a patient has diverticulosis or diverticulitis, excuse me, where is the most common area of the pain going on? Lower left quadrant. Appendicitis?
Lower right.
Lower right. Okay, usually when it comes to diverticulitis, guys, it happens mostly in the descending colon. Therefore, you'll have your lower left quadrant. And a patient that has appendicitis, of course, lower right quadrant. Okay. And what's the point called? McBurney's point. And what's the type of pain called? Rebound tenderness. Okay, good. What can happen if the appendix or the appendicitis or the diverticulitis ruptures? Peritonitis. Sepsis, yeah, peritonitis. When a patient has a surgical procedure, we give anticholinergics, right? We give a lot of medications that depresses everything. Is it uncommon to auscultate bowel sounds and not hear anything?
Yeah.
Yeah, it is. For how long? Do you guys remember? I'm not testing you on that. I just want to know if you guys remember. Usually it can be actually up to a couple days. Remember constipation or no bowel movement 3 days afterwards? Just remember this stuff. It won't be on the test, but I want you guys to remember that. After a patient has had some type of surgery, they will have absent bowel sounds. Okay, so that's pretty normal. They will have a little bit of bleeding. Okay, usually if it's more than 3 centimeters of a blood spot, that means if it's more than 3 centimeters, that means it's excessive. But about 3 centimeters or below, that's expected. Okay. You guys know what the valsalva maneuver is? The valsalva's maneuver. Yeah, the valsalva's maneuver is something that we still use. We still do it sometimes. Essentially, what the patient is instructed to do is to take a deep breath and bear down. Okay, that's a valsalva maneuver. Sometimes it decreases the heart rate. Sometimes it causes too much intracranial pressure. You'll pass out. Okay, but understand that it increases the intrathoracic, intra-abdominal pressure. Okay, and it brings down the heart rate. So if I'm asking you guys about the valsalva's maneuver, again, we know that it's like when you guys defecate, when you guys have a bowel movement, and if you're straining a little bit, you're performing the valsalva's maneuver when you're pushing down, when you're bearing down and straining. Now, what does that do again?
It lowers your heart rate.
Lowers your heart rate. What does it do to the pressure? Increases pressure everywhere, intra-abdominal, intrathoracic, intracranial. What can happen in the brain if you perform the valsalva's maneuver? Aneurysm, right? What happens if your heart, if you perform a valsalva's maneuver? What's a patient at risk for?
Say that word.
If the patient performs a valsalva's maneuver and they have a weak
Low
heart,
heart rate.
okay.
Cardiac.
Okay. Well, if you have some type of heart issue, your heart can rupture. If we're talking about rupturing of a blood vessel, rupturing of the heart, what could happen to the abdominal cavity if you perform the valsalva's maneuver? Some type of hernia or rupture, correct? I want you guys to get into the line of thinking of intracranial, intrathoracic, intra-abdominal pressure. So if you have a lot of pressure, you know what it's going to lead to. Does that make sense? Okay. Yeah. Usually patients with some type of colon cancer or any type of colon cancer, usually what will their history bring up about their diet? What are they lacking? Fiber. What can you recommend to increase or to decrease the likelihood of them developing colon cancer? Increase fiber. Okay, good. What's the most common type of hernia? Inguinal. Yes.
Are there going to be questions from the last class?
Yeah.
Okay, then I can read that.
Does that sound? Because some of these kind of sound familiar. Is that why? No. Which type of medications, guys, will lead to GI upset? Upset stomach, guys. I'm talking about like hyperacidity. It's going to irritate the stomach. Signs of IBS. What type of medication is going to lead to constipation? Narcotics. Opioids, right. You guys know what happens if you what type of antagonist can you give a patient if you give them like too much morphine, let's say? What medication will reverse the effects? You guys remember? Yeah, Narcan. Good. It's important to know. What's the condition of a stoma? What's it supposed to look like for an ileostomy or colossal? Beefy red, pink. Moist or dry?
Moist.
Moist. Okay. Do they have any sensation on the actual stoma?
No.
No. gonna happen to the patient's overall well-being if they have chronic diarrhea? What complications are we looking at? Dehydration. Yeah, excoriation of the bottom. Anytime a patient goes into surgery, guys, what type of medications you want to stop a week ahead?
Aspirin.
Aspirin, anything that might thin the blood, that's right. What happens if we abruptly stop corticosteroid use?
Adrenal crisis.
Adrenal crisis, adrenal insufficiency, right. What's my blood pressure gonna look like if you suspect the patient's bleeding a lot?
Low.
Low, right? Significantly low. Or relatively low. You guys know the difference between significantly and relatively low?
Just a little low.
Well, significantly is below 100. Okay, this is not gonna be on the test. I just want you guys to see what I'm trying to talk about. Yeah, significantly would be like below 100. We know that that's the number, right? But relatively low, it's like my blood pressure was 150 over 80, and like 10 minutes later it's like 110 over. That's
That's
okay.
Change.
That's a big change. Yeah. That's relative. Can the patient do heavy lifting after any type of abdominal surgery?
No.
Okay, good.
No more than 10 pounds.
Yeah, that's right. What's the fluid in the ileum going to be consisting of? Let's see if we get the answer. Yeah, it's usually water. How about in the colon? More well formed. How about in the cecum? Semi-watery, right? Where is the sigmoid colon located, guys?
The left lower quadrant?
The lower.
The lower left corner. What's diarrhea? So that's the fat in the stool. That's good. Did I ever talk about celiac disease? I talked about this, but I didn't tell you guys it was called celiac disease. This is an intolerance to gluten, to foods with gluten. You guys remember what gluten is?
Yes.
Foods that have barley, rye, wheat. So it's called celiac disease. Pretty much your body's inability to tolerate food with gluten. Okay. That's what celiac disease means. Yeah, they cannot tolerate. Some people say they're allergic to it. It's just that their body has a hard time breaking it down. Anybody have celiac disease in here? No? Okay, yeah. Usually, I mean, I can eat anything, but... What causes your typical diarrhea, guys?
The flu.
Yeah, some type of infection, bacterial agent, viral, yeah. What's a continent ileostomy? So your ileostomy, your traditional ileostomy is an incontinent ileostomy. What would be an example of
When you go with the
incontinent ileostomy? Yeah, well, let's give me an example of what we talked about last week. Skokie, you remember?
Incontinent.
A continent ileostomy. You said it a little while ago. Yeah, the cock pouch guys. Remember the cock pouch?
Oh, okay. Yeah, the cockroach.
Yeah. Remember I talked about it. Now you guys knew this because I talked about it last week, but you guys didn't hear it referred to as a continent one. Essentially, it's kind of because you're in charge of when you empty it out. We take that little syringe inside the stoma and we aspirate the fluid. Remember the little bag? It looked like a little bag containing ileum. Okay, that's connected to the wall. That's considered a continent ileostomy. How can we prevent transmission of any type of infectious agent?
Stay out of the hospitals.
That's true, yeah, that's true. Those are called nosocomial, yeah. When it comes to hernias, guys, I think this is the last thing I want to talk about. When it comes to hernias, what's an incarcerated hernia?
Like,
A non-strangulated one.
Okay. What's a incarcerated hernia? Can you go back and, when you're in jail, guys, when you get out?
Yeah.
no.
Well, I mean, after you're done.
Oh Lord, no. You play the what if this? What if what's that show called? Prison Break? You guys ever watch that show? That's an awesome show. But anyway, incarcerated means that the tissue has gone out of its wall and it's entered another place, but it can't go back. Now, what if the physician's going in, he sees me with a bulging thing on my groin, and it's a hernia, and he's putting pressure back into it. Incarcerated is irreducible. What's this one? Reducible. Okay, reducible. It's a reducible hernia. Okay. What's the worst one that you can have? Strangulated. What happens there?
Blood cut off.
Yeah, the circulation stops. Okay, you guys have any questions? No?
Not yet.
Okay, get your recorders and then we'll talk real quick before I let you guys go.
Mm-hmm.